Dear Chair, dear IPC, thank you so much for the kind invitation to talk about a topic that's quite challenging, namely drug-induced psoriasis. And I thought by starting a little bit in the theme of the zoo, because it's really nearby, and showing you the big five in Africa, and either you want to meet these animals or you want to avoid them because they are harmful. And I thought it's a good analogy to talk about the big players in psoriasis. We all plaque psoriasis, pustular psoriasis, PSA, but there's this little guy here, the mosquito, that's quite harmful as well. And I think it's a fitting analogy of drug-induced psoriasis, but this can be quite annoying as these little mosquitoes as well. And why is it challenging? We all know that there have been described several medications that can either induce de novo psoriasis or tend to exacerbate existing psoriasis. And traditionally, there have been strong associations mentioned for medications like beta blockers, lithium, terbinafine, and anti-malaria drugs such as hydroxychloroquine. And especially, I think, with the emerging use of immune checkpoint inhibitors, this so-called immune checkpoint inhibitor-induced psoriasis, I think we will see that much more in the future. But really linking a specific medication to either onset or exacerbation of psoriasis can be quite difficult because the clinical and histopathological features of this drug-related psoriasis can be really difficult to distinguish from the non-drug or classical types of psoriasis. And what it even makes it worse is that the latency between onset of the offending drug and the development of the skin lesions can really vary, and there have been described lengthy onset after years. So that's really difficult then to really link that specific medication to the psoriasis. And lastly, even for these traditionally strong associations, if you look at the literature, the quality or the level of evidence is actually quite low. To illustrate, I would like to highlight this recent case from Canada, and we have a gentleman in 70 years of age who presented in the clinic who had a 2-minute history of this psoriasiform skin rash. He was known with psoriasis, but it was always mild, and it was in remission, complete remission for several years now. And he had multiple comorbidities, including hypertension and cardiac failure, and he used a number of medication. And quite recently, he was started with a sodium glucose uptake inhibitor, dapagliflozin, 7 weeks prior to the onset of the rash. This triggered the clinicians to biopsy this skin rash, and it showed features that are consistent with psoriasis, so an psoriasiform dermatitis. They also saw a lymphohistiocytic infiltrate in the dermis, and also occasional eosinophils. And especially the last one was the clue to assume a possible drug-related induction of psoriasis by the sodium glucose uptake inhibitor. They counseled with the physicians of this patient, and they discontinued that specific drug. And within 6 months' time, with only topical treatments, the skin rash disappeared, became in remission, and at the time of the writing of the case report, I think it was almost 2 years further, there was no exacerbation of the psoriasis skin rash. So probably this is a true drug-related or drug-induced type of psoriasis. And it is of clinical benefit to diagnose it, because the outcomes can then be quite good. Just a step back, we're talking about drug-induced versus drug-aggravated psoriasis. And the difference is that in drug-induced psoriasis, if you stop the offending drug, then the psoriasis will resolve in time. And this specific type of drug-related cause tends to occur in patients without any personal or family history of psoriasis. Whereas the other form, the drug-aggravated types, then you will have a discontinuation of the offending drug. However, the skin rash will remain progressive, and this tends to occur in patients who do have a history or personal or either family history of psoriasis. And of course, in the drug-aggravated types, you can also have the effect that not only the existing psoriasis skin lesions get exacerbated, but you get also development at uninvolved clinical body sites. I think it's good to mention that there are no standardized criteria to cluster or classify drug-induced psoriasis, and it always makes it also difficult to evaluate the literature because we don't have any clear consensus or gold standard what we can either diagnose these drug-induced forms. However, there is a specific probability scale developed by Naranjo and colleagues back in the early 1980s. And this is a simple set of 10 questions in which you can, with more confidence or less confidence, link a specific drug to a specific outcome. I'm just wondering, by show of hands in the audience, who knows the Naranja and uses it in clinical practice? I see one or two hands maybe. So it can be a quite helpful tool. One of the questions is there a temporal relationship? Is there previous reports of this specific association? However, there are some questions that are not typically easily answered in clinical practice. For instance, question number 6, if you have a placebo, if you get the same reaction, I think in most settings that will not be helpful to do. However, if you can manage to answer these 10 questions, you will get a score, and you can either have then a doubtful relationship increasing up to a definitive probability scale. And I think it could be helpful in clinical practice, but also for research purposes to apply this Naranjo scale. So what about the clinics of this drug-induced psoriasis? And actually, it's in line with the previous presentations where there's a really wide range of skin reactions that we can see. It can either be an exacerbation of a pre-existing plaque type, but it can also, for instance, be a morphological change to a more pustular form or a palmoplantar involvement. I would also like to highlight that erythrodermic exacerbations have been described to certain medications. So if you tend to see a patient or analyze a patient with erythrodermic psoriasis, I think a drug-induced cause is one to keep in mind. What has also been described, and Professor Lambert also mentioned it, the psoriasiform aspect of the skin rash, meaning it resembles the psoriasis, but several of the key clinical aspects, either the sharply demarcation or the scaling without the Candle sign, that can be clustered as a psoriasiform dermatitis, and that could be a trigger to think about a possible drug-related cause. And I think this message that if you encounter a patient who has a flare of his or her psoriasis in the absence of any known other triggers, such as infection or emotional stress, I think a drug-related cause is definitely one to keep in mind. Could skin biopsy help us then to establish a drug-induced psoriasis? Well, the difficult thing is that the histopathology versus a drug-related and a non-drug-related psoriasis can overlap quite significantly. There are, however, some clues that can be offered by the pathologist. I think especially the first one, where there is a sort of lack of capillaries in the upper papillary dermis without the associated epidermal thinning and a low number of microabscesses in the epidermis that can be a histopathological clue. We always think about eosinophils when we think about drug-related causes, and it can indeed be a histopathological clue, but the absence of an eosinophilic infiltrate does not exclude a drug-related cause. And I think finally, more atypical reaction patterns, either a lichenoid or a spongiotic dermatitis, can also be seen in the context of a drug-induced psoriasis. So what are the drugs that we're talking about? And I think some of the associations you have heard previously, so the beta blockers, the hydroxychloroquine family, the interferons, and also I think the novel drug associations. I will discuss several of these. I think one clinical clue in mind is that the latency period can vary significantly, either quite short, and that's been described traditionally to terbinafine and NSAIDs, versus quite lengthy in the case of beta blockers and lithium. So talking a little bit about beta blockers, because that's one of the most strongest associations that we learn about in residency. And it's actually several of these oral beta blockers that are used for hypertension or cardiac arrhythmias that have been linked to either the development or exacerbation of psoriasis. And it's actually a general class effect. So the cardioselective, but also the non-cardioselective beta blockers are implicated in psoriasis induction. And this is, for instance, a case in which propranolol was used as treatment for infantile hemangioma in a one-year-old female patient who developed within 1 week after starting the beta blocker treatment this psoriasiform skin rash without a family history of psoriasis. And also, I think good to keep in mind is that also topical beta blockers that are being prescribed by the ophthalmology department for glaucoma can be linked to a exacerbation or induction of psoriasis. So I think the relatively long latency is, I think, good to keep in mind in clinics. What about mechanistically? Not, I think, a clear-cut case, but frequently implicated is a disturbance in the intracellular calcium levels that also disturb the cyclic AMP levels, which then are a driving force to proliferation of the keratinocytes, which can then be harmful for psoriasis patients. Epidemiologically speaking, there are conflicting data. I think this is one of the largest studies from the US, the Nurses' Health Study, in which they demonstrated that long-term use, meaning 6 year or longer use of continuous beta blocker use, is indeed associated with an increased risk to develop psoriasis. And one case from my own clinics was a gentleman in the 70s who had, who I saw from a palmoplantar psoriasis and general itch that started 3 months after having started both metoprolol and lisinopril, and I couldn't get it under control with topical treatments, and then the cardiologist stopped the metoprolol because his cardiac arrhythmia was treated with cardioversion, and then within 6 months' time, both the itch as the palmoplantar psoriasis disappeared without active treatment. So that's also, I think, a clinical clue that it was a drug-related psoriasis. Lithium used in psychiatry is, I think, always a difficult issue because lithium, there are not always clear alternatives to discontinue this for these psychiatric comorbidities, but it's linked to both induction of psoriasis and exacerbation of psoriasis, and the exacerbation tends to occur a little bit earlier versus the induction of de novo psoriasis. This specific form of drug-related psoriasis is linked to the ability of lithium to deplete inositol, which is a naturally occurring sugar in the human body, in literature it has been described in small case series and in a small randomized controlled trial that if you supplement with this specific inositol, then you might improve this lithium-induced or lithium-related psoriasis, which most often is therapy recalcitrant to our typical anti-psoriasis agents. Other drugs that are linked typically to psoriasis include the hydroxychloroquine, terbinafine, interferons, NSAIDs, and imiquimod. It's not for all these drugs clear what is the underlying mechanism. I think for some of these, it really fits with the current pathogenesis, for instance, the type 1 interferons and the imiquimod, which is a stimulating of the endosomal toll-like receptor signaling pathway that Professor Gillet beautifully described. But for other drugs, it's not really clear. And it can either be perhaps a direct drug-related effect, but also maybe indirect drug-related effects like a drug-induced photosensibility, which then via Kapner mechanism lead to psoriasis. In general, if there is a possibility to withdraw the offending drug, I think that's the holy grail in cases of a true drug-induced psoriasis. But if it's that not possible, then you of course have the typical treatment options that we have for non-drug psoriasis types as well. In my final segment, I want to talk a little bit about the immune checkpoint inhibitor-induced psoriasis, because I think this is one that, because these agents are used more frequently by the oncology department, we will encounter quite frequently. More than 70% of these patients develop one or more cutaneous toxicities, and psoriasis is one of these described skin reactions to these immune checkpoint inhibitors due to the T-cell overactivation. An interesting cohort study from Taiwan showed among a high number of patients who were treated with an anti-oncological treatment, so that could either mean chemotherapy or these newer immune checkpoint inhibitors, that patients who are treated with these immune checkpoint inhibitors have a twofold increased chance to develop psoriasis compared to more conventional traditional chemotherapy. The time of onset can be quite variable, and the most reported subtype in these patients is the plaque type. This is a patient that I saw a couple of months ago, a patient in the 70s who was treated for her endometrial carcinoma with an immune checkpoint inhibitor, durvalumab, and after 3 courses of this IV treatment, she developed this quite widespread skin rash. She had no personal history of psoriasis, and none of her family members was known with psoriasis. We treated it with a topical calcipotriol betamethasone ointment, and the skin rash cleared very well within 1 month time. So how do we treat these patients? Because most often, of course, in these patients, you are preferred to continue the immune checkpoint inhibitor if it has a positive effect on the malignancy. And of course, it's then a case-to-case counseling with the oncologist and the patient. And here are some of the factors that can play a role in that discussion. Treatment interruption of the immune checkpoint inhibitor treatment is likely not to improve the skin rash, so I think that's not something that you will then recommend. And if topical treatments are not sufficient, these expert-based recommendations either use systemic retinoids because of their non-immunosuppressive effects, but also IL-23 biologics have been recommended. And this is a case of a gentleman from Brazil who was treated with nivolumab for a metastatic gastric cancer, who developed this new onset of psoriasis 6 months in the immune checkpoint inhibitor treatment, and he was treated with an IL-23 inhibitor that was effective, but also safe in terms of adverse events and no effects on his malignant disease. I would highlight also this case because it's not always also the immune checkpoint inhibitors, but also the traditional chemotherapy. This is a patient that I saw a couple of weeks ago who was treated for his AML with chemotherapy and who developed this newly onset psoriasis after 2 courses of chemo. And of course, you will start then with topical treatments, which I did in this case as well. But if not sufficient, then I perhaps would consider medications like acitretin if needed. So with that, I would like to conclude by sharing with you these take-to-clinic messages that drug-induced psoriasis can be challenging to recognize, especially in the context of patients who are treated with a multiple myriad of medications for their comorbidities, and also this variable latency periods taking into mind. I think from the clinic side, any psoriasis flare without any other noticeable trigger factors should raise the possibility for a drug-related case. And I think that histopathology can be helpful, but if you don't see an eosinophilic infiltrate, that doesn't exclude a drug-related cause. And finally, I think that detailed medication review is, I think, always good, and also multidisciplinary management is essential, not only to improve skin outcomes, but also other outcomes for the overall outcomes for these patient groups as well. And with that, I will give the word back to the chairman.
Excellent. Thank you very much.